Okay, good morning, everyone. It's 8 a.m. and we will get started on this beautiful, warm spring day in Wisconsin. Thank you, everyone, for coming here, and thank you for those online. Just a quick update. If you are here in person and you parked in lot 75, we now will validate parking. We have stickers, we have validated tickets in the back. And for those of you who are listening online and want to come in person, we will provide parking as an added incentive. So with that, we will get going. I will be doing the introductions today. And I am absolutely delighted to have two outstanding speakers from our own division of rheumatology. First, I will introduce Dr. Jon Arnason. Dr. Arnason did his initial training in Iceland and obtained his medical degree from University of Iceland, and then completed a residency at St. Joseph's Hospital in Reykjavik, and then came here where he then repeated his residency program in medicine and then continued a fellowship in rheumatology. He has been in practice both in Wisconsin and Iceland, and then returned to UW in 2010 and rose up to the rank of clinical professor. His area of expertise is in ultrasound and has a world-renowned reputation in ultrasound. He was appointed to the Ultrasound School of North American Rheumatologists as a mentor in order to promote the use of musculoskeletal ultrasonography to advance the care of patients with rheumatic disease. He's been invited as a lecturer and course teacher in US Sonar, which I'm assuming is Society North American Rheumatology. Great, thank you. And actually was the quoted by the founder and director of Sonar that Jon is one of the leaders of musculoskeletal ultrasound and really has brought in a national and international audience. He currently serves as the medical director here for rheumatologic ultrasound and has played a key role in training of our fellows in this technology. As a result, 75 to 100% of our recent fellows have been able to become ultrasound certified. He has also helped the American College of Rheumatology determine the standards for musculoskeletal ultrasound certification. And if you've never been to his office, he is also a really impressive photographer. A little competition for our own in-house photographer. Really beautiful pictures of, I know there's been some wildlife and birds that I actually admire. So he will be the first presenter, and I will also present Dr. Ann Chodara, who received her medical degree here at UW and completed her residency and chief residency and fellowship program here at UW. She is currently an assistant professor here and is the associate program director for our rheumatology fellowship program. She is also certified in the use of musculoskeletal ultrasound in patient care. In addition to her interest in musculoskeletal ultrasound, she has added research interest in connective tissue disease-related interstitial lung disease, and she and Dr. Sharkey, who is here, Dr. Malik and others in pulmonary medicine will be launching our first interdisciplinary ILD clinic, pulmonary rheumatology ILD clinic. I think in August is the current start date. And she has authored several manuscripts and a recent book chapter. So with that, I will hand over the microphone to Dr. Arnason.
Good morning. Thank you, Dr. Schnapp, and thank you for the invitation to give grand rounds. Dr. Chodara and I are going to be talking about how we use musculoskeletal ultrasound in our clinical practice in rheumatology. We have no relevant financial disclosures. And our objectives here today are to describe how we use musculoskeletal ultrasound in rheumatology. We're going to be going over the main, all right, the main indications, and also touch on the future applications of ultrasound in rheumatology, both here and elsewhere. So this is not going to be a technical talk, and I'm not going to go into the details about the physics of ultrasound, but basically what we have is a machine that has what we call a transducer, which is both a loudspeaker and a microphone that sends sound waves, listens for the echo, then a computer that you can play with, translates the echo into images. And it doesn't have to be more complicated than that. Ultrasound has been in development in medicines for about 80 years. The first images weren't really images, they were just lines, squiggly lines on a screen. But in the 1970s, so-called grayscale images started to appear, which basically gave a ghost-like image of what we were looking at below the surface. Other developments that we use in rheumatology, in addition to the grayscale, which has improved greatly, a Doppler flow ultrasound, or flow Doppler ultrasound, which shows us the blood flow within the synovium, which can allow us to detect synovitis, and elastography, which is used, for instance, in salivary gland ultrasound, and can tell us about the density and the firmness of the tissue. The earlier machines, they were large, they were fixed, they were expensive, and even though they put wheels underneath them, they weren't really that easily transportable. I remember when I was a med student, I saw machines like these in the hallways of the hospital, and they came in sets of 2, and they were not really easy to manage. Gradually, though, the machines became lighter, cheaper, and more portable. This is how it stands today. Many of us use machines that look like this. They look like big laptop computers. You can fold them together, you can carry them with you. This is our main machine at the West Clinic, and this spaghetti of cords here tells you that we have several probes we can choose from. And the future holds that we will have handheld machines, even cordless machines. They're not quite there yet for musculoskeletal ultrasound because we need high frequency probes to get good resolution in the superficial tissues, and they don't have that yet, but that's probably going to be coming in a few years. With the machines becoming smaller and less expensive and more manageable, the quality of the images has actually improved. I did a PubMed search on rotator cuff ultrasound, went as far back as I could to find usable images. This is from 1988 from Jeff Kress, which was one of the pioneers in musculoskeletal ultrasound. 10 years later, the image quality has improved. We're looking at the supraspinatus tendon attached on the greater tuberosity of the humerus. 2008, we actually see details of the tendon structure, and there's a small tear right there. Even more detail, 2018, and this is an image of my own supraspinatus tendon with our best machine, and I think it looks great. I hope you agree, but I will probably look back 10 years from now and say, okay, we could have done a lot better. So rheumatology, musculoskeletal ultrasound is a point-of-care ultrasound. Many specialties use point-of-care ultrasound, and it's really been within the 20 years that has developed with those fast and cheap and portable, well, not really cheap, relatively inexpensive equipment. Europeans were way ahead of us in rheumatology, but in recent years, 5 to 10 years, American rheumatologists have been catching up. So what is the difference between what we do in our clinic with point-of-care ultrasound and what the radiologists do? So point-of-care ultrasound by a rheumatologist is combined with a history and physical exam. It's usually done for a specific condition to answer a specific question. Does the patient have synovitis? Are there erosions? Are the tendons okay? Is there an effusion? And it's done at the point of care, it's done in the clinic, and it's often immediately followed by an intervention, either aspiration, injection, or change in the management of the patient. Consultative ultrasound by a radiologist, which we still use, is done by a sonographer. It's interpreted by a radiologist. It's usually a comprehensive anatomical study of a joint or an extremity. And it's done at a separate appointment, not integrated into the clinical care at that specific time. Even though the point of care ultrasound is, well, maybe sort of free flowing and can be done at the spur of the moment, there is some rigor to it. And for instance, we have to get standardized images of the joints that we're looking at before we can allow ourselves to make a decision based on those images. For example, this shows you the standard images of an elbow. There are 3 anterior images, there's a medial, there's a lateral, and there are 2 to 3 posterior images. If you see what you're looking for in those images, you may not have to do a whole lot more. But if you don't, or if you need to explore it further, then you have the ability to improvise. And you can scan the entire joint starting at those specific predetermined images. You also have the ability to do dynamic scanning. Have the patient move, see how the tendons move, see if there is an entrapment, see how the fluid moves within the joints. And like I said, it has a direct impact on clinical care. The images that we obtain, because they're really formal part of the patient's management, they are stored in packs, and the findings, our interpretation, is recorded in the patient record. Both the American College of Rheumatology and EULAR, the European counterpart, have position statements on the use of musculoskeletal ultrasound. Our American College of Rheumatology statement is old, it's currently under revision. But from that, the indications for point-of-care ultrasound are joint pain, swelling, or mechanical symptoms without a definite diagnosis, where basically you can't establish a diagnosis just by history and physical alone. This is very often done to look for low-grade synovitis. I'll go a little bit into that later. In patients who are big, in anatomically abnormal joints, when it's difficult to examine the joint thoroughly. It's done for periarticular pain, very often to look for tendinitis or enthesitis, or if you suspect a peripheral nerve entrapment, like carpal tunnel syndrome, for instance. There were hopes that you could use or should use musculoskeletal ultrasound for routine management of inflammatory diseases like rheumatoid arthritis and psoriatic arthritis. Subsequent studies have shown that that is not really practical. It doesn't really add enough information to change the management longitudinally. So it's not done for everybody. We do it initially to look for synovitis if we're not sure. And then we do it in selected cases if the response to treatment does not meet our expectations. And I'll show you an example of that. We use it to guide procedures, not every joint every time, but in, for instance, obese patients or where the joints are deformed. Tendon and tenosynovial spaces are very small. Ultrasound is great to put a needle right there. We inject enthesis, we inject bursa, we do nerve injections or periphery of nerves. So ultrasound has really opened up doors to do many procedures more safely and more effectively. There are limitations to musculoskeletal ultrasound done in the clinic. It's usually not a complete anatomic evaluation of all joint structures. For that, we use our radiology colleagues. It's also operator dependent. Those who do it, they need to be trained in it. They need to know what they're doing. And ACR offers certification, and UW here credentials those who do musculoskeletal ultrasound. It requires experience and definitely a good knowledge of anatomy, because I really had to relearn anatomy differently from what I had learned as a medical student. The equipment also varies, and you need to be comfortable with the equipment. And that's an example of that. Here are 4 images of the same structure, different patients though, but it should look very similar. It's the subscapularis tendon in a transverse view, and it looks quite different from different machines. Those are all modern machines, they're all good machines, but they give different images. And that basically means you need to know your machine and know what to expect so you can interpret what you're looking at. So traditionally, rheumatologists use their history and physical, and then they supplement their findings, get more data by imaging. X-ray initially and MRI. That's the way it's been. Ultrasound is now coming in and may sort of upend that order a little bit. For instance, for synovitis, ultrasound and MRI are both excellent to pick up inflammation that we can't see and can't feel with our fingers. Erosions can also be seen both with MRI and ultrasound. Joint effusion, small effusion, can be picked up equally well with ultrasound and MRI. Tendon pathology, ultrasound is quite competitive with MRI to see torn tendons, tendinopathy, inflamed tendons. And crystal deposits, sort of unexpectedly, ultrasound comes in very strong in even getting diagnostic information on both gout and pseudogout. Soft tissue masses are probably better evaluated with MRI. Bone pathology, ultrasound has very limited role. Cartilage is difficult to evaluate because it's mostly water and it doesn't really show up well. Actually, it shows up as nothing on ultrasound. That's how we detect it. Ultrasound is really the modality for a dynamic study, better than any of the others. It can be used to guide injections where MRI basically cannot. Can be done at the point of care, no radiation, and only moderate expense. So ultrasound, in many cases now, comes even before X-ray, and certainly as a consideration before ordering MRI on your patients. So a few examples how we use it in diagnosis. So we use it a lot to detect synovitis. And not only do we detect it, we grade it. 0 is normal, grade 3 is flagrant synovitis. That typically is not missed with a physical exam. But grade 1 or 2 can be subtle. And we look at the thickness of the tissue within the joint. And we also look at the amount of Doppler signal within the joint and put that together to make a grade from 0 to 3. The detection and grading has a pretty good intra-reader reliability, especially when it comes to power Doppler, which gives up to 97, 99% agreement. And compared to MRI, the sensitivity and specificity of ultrasound is actually quite high. It's not identical to MRI. And I really look at those two modalities that maybe one is not necessarily better than the other. They're complementary. They show us the joint in a little different manner. So here's an example of a shoulder exam. The probe is put here in a transfer location, anterior shoulder. This is normal. We see the humerus. We see the biceps tendon surrounded with a little bit of fluid, and that's normal. This is the patient's view, and you see a huge effusion. This would not be missed with a physical exam. But it has also internal echoes, so-called snowstorm appearance, which is very indicative of either gout or pseudogout. And this particular patient has CPPD. This is another example of an effusion. This is in a knee. The probe is here in the suprapatellar recess, transversely. You look down, you see the quadriceps tendon, you see the femur down here at the bottom, 2 fat pads, and a very small effusion in between. And you can look at the recesses, lateral or medial recess, and see this little drop of fluid. This is probably normal, but we can see just a few cc's of fluid in even a big joint like the knee with ultrasound. Tendon pathology. Ultrasound is really good in helping us evaluate tendons. This is the Achilles tendon. It looks like a rope, strong, thick tendon, attaches here on the calcaneus. There's a little bursa right there with fluid, that's normal. And if you look at it transversely, it looks thick, uniform, intact. This is the patient's tendon. She has ankylosing spondylitis. She's had problems with tendon pain. And here you see the tendon is thickened. You lose the internal linear structure of the fibers of the tendon. And in a transverse view, it looks almost like it's moth-eaten. And if you put the Doppler on that same patient, you get increased Doppler signal both within the tendon There should never be internal Doppler signal in a tendon. So you get internal Doppler in the tendon and also at the enthesis. So this patient has both Achilles tendonitis and enthesitis. A real patient, 70-year-old with a long history of rheumatoid arthritis, used to be quite severe, has suffered a lot of joint damage, but has been stable for over a decade. Now he has a new shoulder pain, and he fears that his rheumatoid arthritis is back. So I examine his shoulder. This is a normal-looking supraspinatus. This is his, looks pretty good until you go into a transverse view, and then you see this defect here in the supraspinatus tendon that extends almost all the way through, but not completely. So he has a partial tear, degenerative tear of the supraspinatus. Not a good news for everybody, but he was actually delighted because now he has an explanation for his shoulder pain, and he knows that is not his rheumatoid arthritis. Crystal arthropathies, like I mentioned, ultrasound can give diagnostic information. This is an image of the ankle. There's effusion in the ankle, and you see the outline of the cartilage, which you should not see normally. This is called double contour sign, and this is rather specific for gout. CPBD, calcium pyrophosphate deposition, gives chunks of calcium. This is in a knee transverse view. In the suprapatellar recess, you get chunks of calcium within the cartilage, also rather specific for CPBD. And both can give that snowstorm or starry sky appearance that I showed you earlier. Another true example, a patient with presumed seronegative rheumatoid arthritis that is not responding to treatment, has worsening wrist symptoms after minor injury. This is her wrist, distal radius, the small bones of the carpus, tendon, extensor tendons on top, and you see those like dark clouds here hovering over the joints. This is synovial thickening. There's increased Doppler signal, and you see these little specks, bright specks. Those are actually calcium deposits. And if I look at the medial view of the wrist longitudinally, this looks rather indistinct, and that's actually the problem. You should see the normal fibro cartilage here, triangular fibrocartilage, and it's completely disintegrated and full of these calcium deposits. So she probably never had seronegative rheumatoid arthritis. She probably has had CPBD, calcium pyrophosphate deposition, all along. Nerve entrapment can be seen with ultrasound. This is an example of carpal tunnel syndrome, where you see actually a widening of the median nerve that you can measure, but then it narrows down severely. So this is severe carpal tunnel syndrome, where the nerve is squeezed down to almost nothing, but then it bulges out proximal to the entrapment. And you can do a dynamic examination of, for instance, shoulder, and let's hope that this works. You're looking at the supraspinatus tendon here, and this is the humerus. And when this starts, you could see the tendon retract and the humerus being pulled up against the acromion. And there it is. And this is normal. There is no impingement. If there was an impingement, you would see the supraspinatus tendon get stuck and buckle up underneath the acromion. Bursitis can be picked up with ultrasound. This is subdeltoid bursitis, actually turned out to be infectious. And even though musculoskeletal ultrasound is not the best modality to detect meniscus tear, this is an example of one. This is a lateral longitudinal view of the knee, where you normally see a slightly protruding meniscus. Then you, in this case, see those sort of Mickey Mouse ears here, and also seen on an MRI of the same patient. This is a large degenerative tear of the lateral meniscus with increased Doppler signal around it because it's relatively fresh and is relatively new. So a few examples of how we use musculoskeletal ultrasound for diagnosis. And with that, I hand it over to Dr. Chodara.
you hear me okay? All right. All right, thanks everyone for having me here today. So I'm going to be talking more going into some of the specific procedures and therapeutic applications of ultrasound. We'll also talk more about the training we offer for our fellows here at UW in the Rheumatology Fellowship. And then lastly, we'll move into speaking more on the special applications, future prospects of ultrasound in rheumatology and beyond. So when we're thinking about ultrasound guided procedures, primarily we're referring to aspiration and injection. And as Dr. Arnason has already alluded to, a lot of times we're using this for joints considered more challenging, whether it's because of body habitus, deformity from chronic arthritis, also just joints that are traditionally more anatomically challenging too. There's multiple ways to use ultrasound to access a joint, and I've outlined a couple of those here. What the indirect approach is often what we'll use in very small joints. You're just using ultrasound to primarily triangulate your injection location, but then when you're going in, you're not using the probe to visualize that. Now, the in-plane and out-of-plane approaches are two visualized here. So these are both looking at the knee itself. You've got the probe laid across the suprapatellar area, but you can see the needles coming in transversely across that probe there. And so the way it's visualized is a bright dot that you're looking for. Often, again, useful in very limited area too. So in the foot, we'll often use this as well. The in-plane approach, this one is great when you're wanting to see exactly which tissues you're going through to inject or aspirate a joint. You can ensure you're avoiding vessels or nerves, and so it's very useful there. This was a study looking at multiple joint injections done in 2010. They actually compared a trainee who had about 2 years of ultrasound experience, who did the ultrasound guided injections, and they compared that to more senior experienced rheumatologists who did it anatomically guided. And they found that ultrasound guided injections were more accurate over all the joints they looked at. And it did provide greater improvement in joint function out of a visual analog scale at 6 weeks. So it looks like there's improved outcomes for patients as well. And we'll talk more about that specifically in specific joints. So moving to the shoulder now, these are two of the areas we traditionally will inject more frequently. We've got the glenohumeral joint itself here. This is an example of, as you can see, the needle going right around the humerus into the joint capsule there. The subacromiosubdeltoid bursa is another area commonly injected in cases of rotator cuff tendonitis, or you can see true bursitis on the ultrasound image there too. So in a study looking at 41 shoulders that were randomized to injecting this bursa, either blindly or with ultrasound, there was a improvement in the mean visual analog scale, more so with ultrasound compared to those done blindly. And that was statistically significant in that study. It's something we'll not always do every time. A lot of times we'll consider it for patients if they've already had one done in clinic, didn't have a good response, or again, if they have a very challenging anatomy, maybe some rotator cuff tendinopathy that we want to ensure we're in the right space. And this was from the study I just alluded to with the ultrasound trainee versus the more experienced rheumatologist injecting into the glenohumeral joint itself. And it wasn't statistically significant, but did seem to possibly be a trend toward increased accuracy there. Moving to the hip, this is definitely a joint you want to use imaging guidance to access, primarily for the reason that you're getting fairly close to the femoral neurovascular bundle. And so we know from a study comparing hip injections under ultrasound to fluoroscopy, which is the gold standard, they were 97% accurate. And there were some improvements in terms of, reduced risk of radiation to the patient and shorter procedure time. There were 2 retrospective studies also just looking at the safety of ultrasound guided injections or aspiration of the hip, a number of hips, as you can see, 800 and over 300 there. And there were no major complications, including inadvertent vascular puncture. As you can see, this image nicely shows the needle going right into the hip joint. This is the capsule here. You've got the femoral head and neck. And then again, that's your bundle with the nerve, artery, and vein. The ankle is a complicated anatomic joint on its own, and ultrasound really gives us a lot more access to this area. We're typically thinking of the tibiotalar joint as the traditional ankle joint, but it allows us to access the subtalar area, the tendon sheaths around the Achilles, as you've seen some images, and the retrocalcaneal bursa. And again, when we're looking at accuracy, this is looking at accuracy of injection of the tibiotalar joint versus blind injection. That was just statistically significantly more accurate. This is the posterior tibialis tendon injection and the subtalar area. We have some examples here. So this is one approach to the tibiotalar joint itself. You can see the probe laid across the ankle, the needle going right into the joint itself as well. This is an example of accessing the subtalar area, specifically the sinus tarsi. Again, we've got that implant approach, seeing exactly where we're going, avoiding any of the arteries. And then lastly, this is an example of injection or aspiration of one of the tendons. So this would be the peroneus tendon on the outside of the ankle. This we really would only use ultrasound guidance for, especially if we're thinking about injecting, because we're talking about weight-bearing tendons here. So, when we're looking at the Achilles, the posterior tibialis, the peroneus, that's specifically why we're using that there. And there's a lot of applicability in the foot too. So midfoot osteoarthritis is very common. Inflammatory arthritis can affect this area as well too. And having the ultrasound really allows us to target specifically which of these tiny joints are affected and target those effectively. So this is an example of some images courtesy of Dr. Arnason, where we're looking at the naviculo-cuneiform joint that corresponds here on this image. So, in clinic, you can target what spot's most tender, find it correspondingly on the ultrasound, and inject it there. This is an image of the needle tip within the joint delivering the steroid. Next, the carpal tunnel. So this is another area, again, when we're speaking about safety of injections as well, we're really trying to reduce any risk of injury to the ulnar artery and nerve, often approaching this area from that ulnar aspect. And there are multiple approaches using ultrasound. That's still a little bit up in the air or under debate, I should say, in terms of what's the best approach. But I like this image because what we're really looking at here is that carpal tunnel area in transverse. And this is the median nerve here. You can clearly see the needle coming in. You're avoiding any tendons. You can confirm even with Doppler that there's no artery in the way as well. And sometimes you'll even see some anatomic variance within the median nerve too. So this allows you to successfully detect that, avoid any unexpected vessels, and safely inject. A couple other applications in terms of specific joints. Now the sternoclavicular area and the acromioclavicular area are two joints that we can see fairly commonly involved in different types of inflammatory arthritides. Spondyloarthritis can involve this area. We've seen crystal arthritis, and then of course infection. So you can safely land a probe on this area, aspirate, inject to try to get more information too. And then similarly with the acromioclavicular area, this is just an example of the probe laid right across there. You can see the needle going into the joint. Again, if someone has something like a full rotator cuff tear, even injecting this joint allows you to successfully disperse steroid around that shoulder and hopefully give them some relief. So this is an example of the use of ultrasound in patients who are obese. This is one of Dr. Arnason's patients who graciously allowed photos to be taken. But by looking at, this knee, you can imagine it would be extremely challenging to simply use anatomic palpation to successfully inject or aspirate the knee. And oftentimes in larger body habitus, we're using a curvilinear probe. So it's a lower frequency, and you can see that reflected because these images are pretty grainy compared to the ones we've been showing you. But you can still see the relative landmarks. You can see the femur easily here, quadriceps tendon, and then here's effusion within the joint. Here's the needle going into that effusion, aspirating, injecting steroid, hyaluronic acid successfully and safely. And then moving on to the deformed joints. This is another example. This is a patient who has longstanding rheumatoid arthritis. You can tell there's really been a lot of destruction of that joint and minimal joint space. And ultimately, elbow can already be a challenging joint to access for aspiration and injection blindly. So especially in this case, using ultrasound makes it quite a bit simpler. What we would do is have the probe here, you have it laid right across posteriorly, and you can see this is the olecranon fossa. There's synovitis here, and there's the needle going in. You can ensure it's in the right place, and the patient gets the treatment that they need. So next we'll move on to talking more about the training program we've established here, thanks to Dr. Arnason for the past 10 years to train our rheumatology fellows in musculoskeletal ultrasound. Now this was a needs assessment survey that was sent to 113 rheumatology fellowship program directors, just looking at what they're doing in practice. And this assessment was sent in kind of the mid 2010s too. So, what they found was that 94% of programs are teaching ultrasound in some format, but only about 41% of those had a formal curriculum. About a third did have a once weekly clinic, but it wasn't necessarily integrated into fellow and attending schedules in the way that we are doing it, which we'll talk a little bit more about. About a third of those did split training between diagnostics and therapeutics equally. As you can see, we've talked a lot both about both of those implications of ultrasound, and they both deserve their own dedicated time to learn. There are various formats of curricula fairly similar to ours, and that a lot of it is hands-on experience in addition to some of the didactics. And then barriers identified, course time, this faculty time, trainee time, it does take a significant amount of time just to gain the experience needed to become proficient in ultrasound. Funding as well was also variable in terms of different programs, and then availability of faculty too. And the program directors overwhelmingly favored having formal opt-in curricula because while there's a lot of interest in rheumatology of incorporating ultrasound, it's not always feasible in every clinical setting too. So allowing that flexibility is key. So our ultrasound curriculum here at UW, we'll talk about this and what it looks like. This was data we presented at the American College of Rheumatology Convergence Conference in November of this last year as a poster. And the way it works is it really takes place graduated over the 2 years of fellowship, and it's integrated into our fellows' schedule in that they're participating in ultrasound clinic weekly. One of the new things this year was that we added a second weekly clinic. So Dr. Arnason and I both have established procedure clinics, and then we have fellows rotating with us. You get established individualized teaching both on diagnostic and therapeutic ultrasound guided procedures. And from day one, fellows are performing the procedures. So we've established milestones to allow them to progress at an expected rate. And accompanying that are at period of time, we have didactics listed in, monthly asynchronous assignments on specific joints where fellows are assigned a joint, have to attain those dedicated views, as Dr. Arnason has alluded to, and then they return that, followed by feedback and a grade. And an important aspect, as I mentioned, there's a lot of time needed to learn this process. There are machines at multiple sites. We've got the one at our Junction Road Medical Center. There's one at the VA. We do have access to ultrasound here in the hospital as well, too. And this is an example of the structure of our curriculum too. So it's just through the 2 years. We've got year one across the top, year two across the bottom. And essentially what this is showing is just the spread of the different lectures and the training that we offer. So the blue going through each month are the weekly ultrasound clinics. The red are the didactic lectures. So at the beginning of the year, both years, there's an introductory lecture covering knobology, so to speak, how to use the machine, the basic views. Then there's a technical lecture later in the year going even more into detail on that to best know your machine. The orange blocks represent the monthly asynchronous assignments. So the first year, we're traveling through the different joints that the fellows are assigned to. Second year, that gets tailored a little bit more to further improve their skills. The yellow at intervals are the timings of the evaluation of the milestones and fellow progression to ensure they're progressing appropriately. And then the green bar along the second year is just indicating that for second year fellows, we do encourage them to participate in outside training courses. So we've alluded to US Sonar, which is the Ultrasound School of North American Rheumatologists. They offer a comprehensive training program that takes place throughout much of the year and just expands on what we're already doing here. So giving them that additional experience and including some in-person workshops as well. So our evaluations take the form of course, in clinic, they're getting directed feedback, hands-on experience. There are monthly assignments, as we've already discussed too, with the asynchronous assignment. Quarterly, again, we've established milestones as to how they should be expected to be progressing. And then as part of the fellows' overall competency evaluation, we do offer a biannual evaluation as well of their skills to ensure they're progressing. The support to participate in these outside courses, as I mentioned, that's part we encourage and we support that. And so ultimately what we're finding, our fellows are able to get at least 150 procedures or examinations during the course of their fellowship. And that does allow them to meet criteria to sit for that ACR rheumatologic musculoskeletal examination. And this is a nationwide offering that allows one to be credentialed in musculoskeletal ultrasound, to practice independently, bill insurance. So that's a key part of a training program. So in terms of outcomes, of the 9 fellows who have gone through this ultrasound training since 2013, 5 of them obtained the scholarship through US Sonar. That's that outside training program. It's a prestigious accolade because you're competing against fellows from across the nation and allows you to fully participate in that program. 7 of them at this time are RH MSUS certified, so practicing independently, and 8 are currently using ultrasound in their clinical practice. So we consider that a success. In terms of next steps, what we're hoping to do in the next years are to add additional teaching faculty. We do have training faculty both at UW and at the VA who are hoping to incorporate this in the next few years. We plan to expand the assignments that we offer as well into more detail and specific areas such as Myositis, for example. And then ideally, we'll be looking into more formal faculty training to improve our educational skills and what we're offering as well. So next, moving on to some future prospects or special cases, I would say that ultrasound is being used. We'll go through a couple here. Some interesting areas, including vascular ultrasound, looking at large vessel vasculitis, salivary gland elastography and Sjogren's syndrome, applications in myositis, and then finally synovial biopsy. So vascular ultrasound, as with ultrasound in general in rheumatology, has been in use in Europe longer than it has been here. So that's where a lot of the data comes from. We're specifically thinking about diagnosis of GCA and Takaysu arteritis. And there do exist fast track clinics in Europe, and there are some in the US as well, with the goal of trying to get patients in quickly, try to expedite their diagnosis. The guidelines actually in Europe for diagnosis of giant cell arteritis do include vascular ultrasound of the temporal and the axillary arteries. In some cases, they're even using it as in lieu of biopsy, although it is not to that point in the US where we could safely say that. But the idea being to try to expedite this diagnosis to prevent that risk of vision loss we're always concerned about. One study that came out in last year, looking at 78 patients, half of whom ultimately were diagnosed with GCA. They ended up having both temporal artery ultrasound and biopsy. And you can see the rates here of the sensitivity and specificity of these procedures. They were essentially fairly similar, as you can see in terms of sensitivity. The false negative rate of ultrasound was about 5%. But ultimately, they felt that they're fairly similar as long as you have kind of meet some of the few caveats that can happen when we're trying to do vascular ultrasound. I'll show some pictures on the next slide to show you some of the challenges with it. But essentially, if we're trying to look at this, you really need advanced machine, you need high frequency probes, and there is a lot of specificity in the vascular expertise needed. So a lot of these clinics are using trained vascular sonographers who are already having all of this experience, because it is a different skill set than what we're solely doing with musculoskeletal ultrasound. And the challenging thing too is with some of the findings that we can see, they can sometimes persist even despite patients being treated. So in diagnosis, there seems to be a role. However, how to kind of follow these conditions longitudinally is still a little bit up in the air. And this is an example of really what we're looking at here. And these are the vessels we can see. So ultrasound does open up, more areas we can evaluate. So the temporal arteries, you can see the axillary arteries, subclavian and carotid, all of which can be affected both in GCA as well as Takaysu. And so what we're looking at here is something called the halo sign. This is a vessel in cross section, the temporal artery. This is looking at it longitudinally. You can establish it's a vessel with a Doppler flow. And essentially what you're looking at is the thickening of the vessel walls. That can be measured. And what you can do is compress that vessel, just press down with the probe, and you see the flow disappear. However, you still see that thickening persist. There have been some established measurements to say what's normal and what's abnormal too. And so that's essentially what we're looking for in different areas. So more to come with that. Now, if we're thinking about Sjogren's disease, this is switching gears a little bit. These photos are credit of Dr. Sarah McCoy. So she runs our Sjogren's clinic, and she has been incorporating this into her clinic, already doing salivary gland ultrasound, which allows you to assess kind of the status of the parotid, the submandibular glands, looking for concerning lesions and trying to follow the disease. When we're looking at elastography, you've probably heard of it in relation to the liver and other areas, but it's essentially a technique that allows us to assess the elasticity or the kind of fibrotic nature of tissue too. And so these are two examples of a parotid gland. So this is normal grayscale parotid on the left side, you're looking at it. And then this is applying the elastography function here. Take my word for it, that looks normal. It's kind of lower on the scale. But then if we go over this possible lesion of concern, what we can see when we apply that there is you can see a lot more lighting up, so to speak, on the elastography. So that is implying that there's probably more fibrosis and there's some abnormality there. Ultimately, the use of this is something that is still being delineated. Is this something we can use to follow disease activity, to identify maybe the stage of disease too? But certainly looking forward to hearing kind of new evolvements from this. So next, moving to use in inflammatory myopathy. Now, ultrasound is fairly well established in many pediatric neuromuscular disorders, and we're trying to understand its use in the inflammatory myopathies. So these are conditions such as dermatomyositis, polymyositis, occlusion body myositis. We know muscle is very accessible, of course, to look at with ultrasound. That's easy, right? But how do we interpret that in terms of how active disease might be or the stage of disease? This is an example that's been proposed in terms of establishing a grading scale as well in myositis. And so this would be a normal one. And this is looking at the vastus lateralis in the thigh. This muscle looks normal. It's, you can see it's normal echo texture. It's certainly not homogeneous by any means because you're seeing hyper and hypoechogenicity, the normal fibrillar structure of muscle. And then as you start to get kind of graded in terms of more advanced, you can start to see this looks a little more abnormal. You start to lose some of that discrete texture here. It's a little more obvious on this one. You can start to see the echogenicity increase. It starts to look a little more homogeneous actually. And then, getting to the grade 4, that's starting to even look atrophied and just really disorganized too. We do see calcinosis as a feature of many of these conditions, and it can be pretty easy to detect that with ultrasound as well. So it can be a useful adjunct there. At this point, this is something though that further study is needed, especially in how do these results compare to MRI, which is what we're often getting, looking for muscle edema, muscle atrophy in these conditions, and then more study in terms of establishing quantitative measures of how to grade this, more like what we have in synovitis as well is needed. And then lastly, thinking about synovial biopsy and the role of ultrasound. Now, this is something that can be done in certain situations, sometimes in really challenging cases of inflammatory arthritis. We may use this to try to help establish a diagnosis. I would say probably a little more commonly, we're thinking about this when we're trying to rule out an atypical or a fungal infection, especially if someone's on immune suppression and has what looks like active inflammation. Now, this is a procedure that's typically done in the operating room with orthopedics. There are groups in Europe and the United States who have been doing synovial biopsies under ultrasound, and they have published some data indicating that it's a safe and well-tolerated procedure. Of course, the benefit of being able to at least access some joints with ultrasound are that you're not in the OR putting a patient under general anesthesia, so it's less invasive. For that reason, it's less costly, and there is less radiation involved if you're not having to use fluoroscopy as well. Disadvantages are that you don't directly visualize the joint, of course. When it's done in the OR, it's under arthroscopy if we're thinking the case of a knee. There is more limited tissue quantity for that reason as well, since you're using the needle to go into the joint as opposed to having the joint more exposed too. However, with the study where they looked at the safety, they did find that 93% of the biopsies done did yield good quality tissue and RNA for study. So at this point, it's primarily used in the research setting. But again, these groups are offering training and looking to expand the use of synovial biopsy. But again, not something that's currently offered at UW. However, something I look forward to learning more about and seeing how it might expand in the future. So in summary, we've kind of done a whirlwind tour of ultrasound and all its applicability here, but I hope we've convinced you that MSK ultrasound is a safe, well-tolerated point of care tool with a wide array of diagnostic and therapeutic uses in a rheumatology clinic setting. We've talked about our curriculum to train fellows in ultrasound here at UW and some of the future opportunities that exist for expanding ultrasound applicability in rheumatology and beyond. So thank you all. I really appreciate your attendance.
I'm going to ask a question. Thank you. And while questions are coming in, I'm going to ask the first question. Are there any specific findings on ultrasound that indicate an infected joint versus a gouty joint, et cetera? Can you diagnose an infected joint?
Thank you. Good question. No, yeah, thank you. Good question. There isn't really. And in fact, different types of inflammatory arthritis, psoriatic versus rheumatoid arthritis, they look more or less the same when you look at the synovium, and same with an infection. And so when it comes down to it, if infection is a consideration, you have to get a sample of the synovial fluid, but ultrasound can be very useful there to get it from a difficult joint.
Okay, let me take one from the audience. So great presentation. And what do we do if we want a musculoskeletal ultrasound? I'm in clinic and I'm concerned about one of my patients has a joint, or I'm on service and I want help. So how do I request an ultrasound from you guys?
Sure, I can take that. Thank you. Well, it depends on the setting. I will say, oftentimes inpatient, just because of the ultrasounds that we do have access to. If we are, you can hear me okay? Okay. On the inpatient setting, oftentimes we're asking our radiology colleagues to help in that setting, just simply by having more availability as well. We have excellent musculoskeletal radiologists who we work closely with as well. So that would be the best on the inpatient setting. We're happy to attempt, but the ultrasound, they have more access to better ultrasound in the hospital. It's different outside in the outpatient clinic, because then we're available to help as we can.
Thanks for the talk today, guys. My question would be about, are you keeping track of the diseases or your codes on the patients that you're seeing? I see me using this a lot in seronegative type patients. Do you have are you keeping track of kind of the kinds of diseases that you're taking care of?
So you're right. We do typically see a lot of patients where the diagnosis is not clear, and that happens very often to be patients with suspected or confirmed inflammatory arthritis who are seronegative. And it often comes down to detecting that subtle synovitis, the grade 1 and grade 2, and seeing those few specks of calcium that are so small that they don't show up on regular x-rays, but are readily visible on ultrasound. If there is fluid, we can also take sample, but I would say probably half of the time, especially with CVBD, there is not enough fluid to aspirate. So we make the diagnosis based on those specks of calcium in the cartilage and in the synovium in the correct clinical setting.
Then I guess a follow-up is, do you have a database of those patients in the diagnosis in which you use ultrasound and with the findings? Do you have a, no? Okay, that's fine. Okay, a question. A question is for low back pain, is there any role for musculoskeletal ultrasound in the evaluation?
That's a good question. So not typically in terms of an area that we're routinely accessing as well. Oftentimes, since we're talking more about bony pathology, there's more of a role for MRI in that type of scenario. Mm-hmm.
Not yet.
Not yet. Yeah.
Tiffany Lynn, Division of Rheumatology. Question about the ultrasound program for the fellows. As we see more integration and exposure with point of care ultrasound and prerequisite training at the internal medicine residency level, how do you envision that will impact the musculoskeletal ultrasound curriculum for the fellows, and how do you plan to adapt for that?
I think that's an area that we can definitely look into how we can best incorporate that too. Because right now our training has been primarily focused on fellows, but with the advent of POCUS in the residency as well too, we're more than happy to add on training as much as we can.
And basically what it comes down, there is basically only now 3 of us that are doing a lot of musculoskeletal ultrasound, but with more people having that capability, yes, it becomes part of what we do as rheumatologists in years to come.
And then along the same line, as you were presenting, I'm thinking these are very useful skills for the primary care physician as well. So what do you see the evolution in primary care for this?
Yeah, I think there's a lot of applicability. Even at the ACR this year, they, I think it was from Colorado, they actually developed a module in terms of trying to teach primary care providers even just how to detect like the double contour sign, looking for gout, because that's a quick thing you could do in clinic too. So I think that would be something encouraging in the future, how we can disseminate these. It primarily depends on access to ultrasound is what it comes down to.
Yeah, just to add to that, I mean, related to primary care is our areas like emergency medicine, where they're using point of care ultrasound regularly, both for procedures and diagnosis. So ultrasound is sort of gaining foothold in different specialties, both primary care and subspecialties.
Thank you both so much. I have 2 questions, one that's boring and one that maybe is interesting. The boring one is, how do you handle documentation or billing for these sorts of things? And are you sort of saving images into patient records and so forth? And the second is, why is Europe so far ahead of the United States with joint ultrasound?
Take the last one first. Europe is always ahead. That's just a fact. Probably has to do with bureaucracy here in the US for the most part. And I can speak from my own experience because I'm from Iceland, so I know both worlds. What was the first question?
The billing and
Oh, the billing and documentation. Yes, very good question. Very important. So every study that we do has a billing code, and that accounts both for diagnostic studies and procedural studies. So they are entered as a separate billing code apart from the visit. If a patient just seen for ultrasound, then there's no other billing for that. It's just the ultrasound, either procedural or diagnostic. And the images that are obtained, they are stored both on the machine temporarily and transferred to PACS and are available along with our interpretation in the clinic note.
Great questions. All right, I think we are good for today. So thank you so much for really interesting overview. As someone who started in the snowstorm in the ultrasound days, it's wonderful to see the evolution and how it really is improving care of our patients. So thank you both for a great talk. And thank you.